Imagine standing on the edge of a cliff, the wind blowing, the waves crashing against the rocks below, and you're left with two options: take a leap of faith into the unknown, or turn back and face the path you've already traversed. These critical choices are the very embodiment of the decisions doctors and families in intensive care units grapple with each day, as they decide whether to continue or discontinue life-sustaining treatment. Life or death decisions aren't just made on the fly. They require a sturdy backbone of solid reasoning, open communication, and understanding of the pros and cons of potential treatments. However, the gray zone presents a unique challenge. When the knowledge of the relative harms and benefits of remaining treatment options is incomplete, these decisions become even more complex. In today's journal review, we dive deep into a captivating qualitative observational study that explores how doctors and families communicate and argue these difficult decisions in neonatal, pediatric, and adult intensive care units. We'll be examining all of these questions, focusing particularly on decisions made in this gray zone, with the aim of illuminating best practices and identifying missed opportunities. This investigation forms part of the broader Famicom project that digs into diverse aspects of doctor-family communication in ICUs, looking at matters like family involvement, managing conflicts, and handling uncertainty. In this slice of the project, the focus is on the real-life argumentative practices of doctors and families as they navigate the daunting choice to continue or discontinue life-sustaining treatment. By employing inductive thematic analysis, the researchers unearthed and quantified the main types of arguments raised during these discussions. The data were gathered from audio recordings of family and medical team conversations at the neonatal, pediatric, and adult ICUs of the Amsterdam University Medical Center. The term families encompasses relatives or close friends who were present during these dialogues. The study cast a wide net, drawing in 71 doctors and families of 36 patients. The selection was made with an eye for maximum variation to account for factors such as the patient's age, gender, diagnosis, progression of disease, and treatment course, as well as the family's ethnic background and the doctor's gender, specialty, and role. Data collection took place between April 2018 to December 2019. Conversations were included if doubts arose between the medical team or family regarding the best interests of the patient in continuing life-sustaining treatment, and they were held in either Dutch or English. After families expressed interest in participating, they were given additional information and asked for their oral and written consent. From that point onwards, all conversations between the medical team and the family were audio recorded until a final decision was made about life-sustaining treatment. The study's transcripts were meticulously analyzed using MaxQDA 2020. Let's dive right into the 4 phases of coding and analysis that shaped this study's methodology. This is the process by which the team distilled these complex, emotion-laden conversations into quantifiable data. In Phase 1, known as fragment selection, the main researchers determined which of the 101 recorded conversations had doctors and/or families put forward standpoints to either continue or discontinue life-sustaining treatment. Out of the 101, it turned out to be the case in 55 conversations. Phase 2 was the development of the coding scheme. This was done by the main researchers who inductively coded the argumentative practices of both doctors and families in 15 randomly selected transcripts out of the 55. This inductive coding helped the researchers develop a preliminary scheme regarding the content and structure of the argumentation. This content part was then discussed with 3 other researchers, and their input was used to refine the scheme. The structure part was also discussed with 2 additional researchers, leading to further refinements. In Phase 3, the researchers moved on to the actual coding. All 55 transcripts were coded by the main researchers using the refined coding scheme, and any disagreements on codes were discussed with other researchers until consensus was reached. The final phase, Phase 4, focused on analysis. The main researchers compared the applied codes to identify the main types of arguments used by doctors and/or families, to describe the main ways argumentation was structured in conversations, and to identify discerning patterns in how argumentation evolved during conversations, also known as the argumentation dynamics. These outcomes were then discussed extensively by all co-authors in 3 discussion rounds to sharpen them and minimize bias and unclarity. This four-phase process gave the researchers a systematic way of breaking down these conversations, enabling them to pull out key themes and patterns. By understanding the methodology, we can appreciate the rigor and care that went into this research, as we further unpack its findings. So let's move forward and see what insights these researchers unearthed from these deeply personal and complex discussions. The results section delves into the nuances of the data that were collected and analyzed. In this study, 71 doctors and families of 36 patients participated. Most of the medical teams first expressed doubts about whether LST, life-sustaining treatment, was in the patient's best interest, with families voicing their doubts less frequently. The number of conversations it took to reach a decision to either continue or discontinue LST varied by department and situation. The data analysis revealed 10 main types of arguments that were used by doctors and families in support of either continuing or discontinuing LST. These arguments were classified into 4 clusters: treatment-related, patient-related, family-related, and deviating types of arguments. Furthermore, the study explored the structure of the argumentation, focusing on how main arguments and sub-arguments were related to the standpoints taken. In most conversations, only one standpoint was presented, either for continuing or discontinuing LST. A trend was noticed where doctors in the AICU, adult ICU, were more likely to initially present the standpoint to continue LST, but would advocate for discontinuing LST in later conversations. Parents in the NICU, neonatal ICU, on the other hand, primarily argued for the continuation of LST throughout the conversations. Main arguments were often supported by one or more sub-arguments. However, these arguments often appeared to be somewhat abstract and vague, with doctors and families frequently using only one main argument and rarely elaborating on their standpoints. Interestingly, even though the argumentation was often vague, there was not much inquiry from either side for further clarifications. The study also analyzed the dynamics of argumentation in these crucial conversations, with a focus on how doctors and families interacted with each other's arguments. In most conversations, doctors typically initiated the argumentation process, with families responding later. The study found that families did not always react immediately to the doctor's arguments and sometimes provided their response later in the conversation. However, only in a few cases did a real exchange of arguments take place, where doctors and families responded directly to each other's arguments either by supporting or opposing them. In the neonatal intensive care unit, NICU, in response to doctor's standpoint to discontinue life-sustaining treatment, LST, most parents argued for its continuation, often bringing in new arguments. In most cases, these exchanges led to a temporary decision to continue LST. In contrast, families in the Pediatric Intensive Care Unit, PICU, and Adult Intensive Care Unit, AICU, were more likely to align with the doctor's standpoints, either supporting the presented arguments or providing new ones in agreement. In some conversations, where no direct exchange of arguments happened, doctors and families presented their arguments independently, often resulting in 2 possible outcomes. 1. The treatment option suggested by the doctor was followed, or 2. If families strongly argued for continuation of LST, the decision was postponed, and a follow-up conversation was scheduled. Interestingly, nearly none of the conversations culminated in a meta-discussion, where all the presented arguments were collectively summarized and evaluated before drawing an overall conclusion. This observation suggests a potential area for improvement in these discussions, where a comprehensive review of all perspectives could lead to more well-informed and mutually agreed upon decisions. The study's limitations include possible selection bias, as the participants involved might not be fully representative, thereby affecting the study's generalizability. Additionally, only audio recordings of conversations were captured, restricting analysis of nonverbal communication. The potential Hawthorne effect could have influenced the conduct of the participants knowing they were being recorded. Moreover, the study focuses solely on the practices of one medical center, presenting logistical constraints that limit the wider applicability of the findings. Despite these limitations, the study offers several notable strengths. The researchers collected a sizable dataset of real-life, highly sensitive conversations from 3 different ICUs, meticulously analyzing their content. This detailed analysis of actual argumentation practices in these critical settings lends significant weight to the study. The study recommends that doctors become more aware of argumentation in end-of-life conversations. Future research is needed to examine how implementing best practice recommendations could improve the experiences and satisfaction levels of families and doctors during the decision-making process. In conclusion, while end-of-life conversations are among the most challenging aspects of healthcare, this study offers valuable insights into the argumentation dynamics that shape these conversations. By understanding these dynamics and implementing best practices, healthcare providers can work towards more meaningful, patient-centered conversations that facilitate well-informed decision-making at the end of life. The recommendations can be summarized into 3 stages: before, during, and after consultation. Before consultation, doctors should consider which types of arguments are suitable for the decision options and how to substantiate them. These could include generally accepted healthcare standards, uncertainty, medical, effectiveness, proportionality, comparison, patient's quality of life, patient's former wishes and family's substituted judgment, psychological well-being of families, family's moral responsibility, professional authority. Encourage the family to prepare for the argument exchange, with a focus on patient's quality of life, patient's former wishes and family's substituted judgment, psychological well-being of families, family's moral responsibility. During consultation, discuss suitable arguments with the family. Provide detailed explanations of arguments by asking the question, why? Invite families to share their arguments, focusing on areas such as patient's quality of life, patient's former wishes, psychological well-being of families, and families' moral responsibility. If the decision lies in the gray zone, discuss both standpoints, continuing and discontinuing life-sustaining treatment, and substantiate them with arguments. Take time to weigh up all arguments with the family. Avoid discussing arguments regarding a certain decision and taking that decision in the same conversation. After consultation, summarize arguments and decisions, then make a plan for the immediate future. Debrief with other ICU staff members participating in the consultation. Analyze the position presented by the family and strategize on how to meet them. Take time to weigh up all arguments. Plan for the next consultation and share this program with other doctors and nurses.